Jam.
Okay.
కానీ
Okay. ARVC. Introduction. It is defined as arrhythmogenic heart muscle disorder, which is not explained by ischemic, hypertensive, or valvular heart disease. Some have proposed to change the nomenclature to simpler arrhythmogenic cardiomyopathy from arrhythmogenic right ventricular cardiomyopathy, and also at the same time enlarging the arrhythmic phenotypes well beyond the conventional task force criteria specific for ARVC. This is to include other arrhythmogenic cardiomyopathies like LVNC cardiomyopathies and certain phenotypes of DCM where patients are at higher risk of arrhythmias. It is recognized misnomer in that the biventricular involvement occurs in almost 50% of the patients, and small proportion of the patients get predominantly affected only in the left ventricle. So epidemiology, 1 in 1,000 to 1 in 5,000, males higher than females, and predominantly in young adults. So it is usually between the second decade and the fifth decade. It is very rare to see the patients with disease onset more than 50 years of age, and it less than 10 years of age also it is very unlikely, because from birth to 10 years, it is the time required for the intercalated disc maturation, or the time needed for prolonged exposure to exercise, which precipitates the already existing genotype. So it is usually autosomal dominant in inheritance in majority of the cases. Recessive inheritance is possible like in Naxos disease and Carvajal syndrome. So we have to understand the basic pathophysiology. There are in between two cardiomyocytes, there are intercalated discs. These are specialized cell-to-cell junctions, and they are also units of electrical continuity and also mechanical continuity. So the intercalated discs are predominantly composed of three types of proteins. Those are gap junctions, adherence junctions, and desmosomes. So gap junctions predominantly mediate the ionic traffic. So it is used basically for the purpose of functional cell coupling. And whereas the adherence junctions, that is actin filaments, they are anchored and connected to the plasma membrane. So basically it is a structural component, that is mechanical continuity. So what does these desmosomes do? They reinforce the adherence junctions and they fix the adjacent cells, that is the mechanical continuity. Desmosomes bind desmin on the intracellular side, spans the cell membrane, and bind adjacent desmosomes on the extracellular side of the other cell. So the desmosomes predominantly contain plakophilin, desmoglein, desmocolin, plakoglobin, and desmoplakin. So desmo, three desmos are there. That is desmoglein, desmocolin, desmoplakin, and plakophilin, plakoglobin. So these are the these proteins are predominantly responsible for arrhythmic cardiomyopathy. So genomic cause, approximately 60% of the probands will have an identifiable pathogenic mutation, aberrant WNT signaling of the desmosome proteins, as well as direct plakoglobin signaling, which they transfer the myocytes into adipocytes with disease progression. So the three important proteins which can cause ARVC are plakophilin, desmoglein, desmoplakin. So the pedigree evaluation should include at least 3-generation family tree with an emphasis on sudden cardiac death and heart failure, that is prematurely, and also associated cardiac arrhythmias like any syncope, any implantation of ICD in the family member, any implantation of the pacemaker in younger generation of relatives, and also it can also include non-cardiac like skeletal myopathy and renal failure, auditory and visual deficits, which can be associated with certain phenotypes. So clinical presentation. Usually in those aged less than 35 years, the arrhythmic cardiomyopathy accounts for 11% of cases of sudden cardiac death overall. and especially in younger athletes, it accounts for almost 1/4 of sudden cardiac deaths. The annual mortality in a patient diagnosed with arrhythmic cardiomyopathy is as high as 2.3%. So it typically presents between second and the fifth decade of life. New diagnosis in relatives older than 60 years of age is very less likely. Along with the ventricular arrhythmias, the supraventricular arrhythmias are also common, among which atrial fibrillation is the most common. The symptoms and presentation are predominantly palpitations, which has higher prevalence, and dizziness and syncope. The almost 60%, 2/3 of the patients will have palpitations, and right heart failure is present in very less number of people. The predominant symptom is palpitations and arrhythmia. So the cardiac arrest can be the first presenting manifestation of ARVC in at least 1/4 of the people. So there are 3 stages. First one is the concealed stage. The second thing is the electrical stage, and the third is the structural change. So 1:1,000 and 1:5,000 prevalence. So it all includes the concealed, but usually because concealed patients don't come for regular screening, so it is actually underestimated. So what are the ECG changes? There are no ECG changes in the concealed stage, but the electrical stage and the structural stage has ECG changes. If you do a Holter monitor, the concealed stage will be normal. It may record sometimes PVCs, but usually it is normal. So it is basically normal ECG, normal Holter, and normal structure on echo or CMRI. Even CMRI can sometimes miss the concealed stage. So it is almost impossible to diagnose a patient in this stage unless the patient is a relative of a proband. So the next is the electrical stage. So the electrical stage has T-wave inversions, that is ECG manifestations. The patient is usually may not be asymptomatic, but he can have electrical changes like T-wave inversions in V1 to V2, V3, and minor depolarization changes. These T-wave inversions are repolarization changes. Minor depolarization changes like increased activation time and epsilon waves. And also if we do Holter, we can find increased VPC's burden. And there can be subtle structural changes like basal RV wall motion abnormality in either CMRI or echo. The next thing is the structural stage, where obviously the patient can present with arrhythmias. They will have ECG changes. The Holter will show NSVTs or VTs or PVCs, and the echo, even the echo can recognize the dysfunctional RV wall with motion abnormality. So this is the triangle of dysplasia. So initially it was thought that this is the most common site of involvement. So, but this triangle of dysplasia is involved in the advanced stages of the disease, not in the early stages. So it involves the epicardial subtricuspid region and the RV basal wall, that is anterior free wall, RV basal anterior, and also the posterolateral LV wall. So the apex is usually spared. The RV apex is usually spared. So arrhythmias can arise from the RVOT, which is the most common arrhythmia. So Naxos disease and Carvajal syndrome.
ట్రబెక్యులర్ స్పేర్ అవుతుందా?
ట్రబెక్యులర్ కాదు, ఆర్వి ఎపెక్స్.
అంటే ఇన్ఫ్లో అవుట్ఫ్లో.
The area subtended by RV inflow, outflow, and RV apex is triangle of dysplasia. In that, the RV apex is spared. The middle area is involved.
Like orange in gross specimen.
The orange thing is the diseased area.
ట్రయాంగిల్ కి ఏంటి బౌండరీస్ ఉన్నాయా?
బౌండరీస్ ఏమి ఉండవు. ఇన్ఫ్లో, అవుట్ఫ్లో అండ్ ఆర్వి ఎపెక్స్.
ఓకే, అదే అందుకడుగుతుంది. ఎందుకంటే ఇన్ఫ్లో
సో మెయిన్ గా గుర్తుంచుకోవాల్సింది సబ్ ట్రైకస్పిడ్ రీజన్ ఇన్వాల్వ్ అయింది, బేసల్ యాంటీరియర్, పోస్ట్రోలాటరల్, ఎపెక్స్ స్పేరింగ్.
బేసికల్గా పోస్టీరియర్ సైడ్ ఏమో ఎల్వి, యాంటర్ సైడ్ ఏమో ఆర్వి ఫ్రీ వాల్, సుపీరియర్ సైడ్ ఏమో ట్రైకస్పిడ్ రీజియన్.
పోస్టీరియర్ ఎల్వి, యాంటీరియర్ ఏమో ఆర్వి ఫ్రీ వాల్,
సార్కాయిడ్ లో బేసల్ యాంటీరియర్ సెప్టమ్ ఇన్వాల్వ్ అయిందా?
బేసల్ సెప్టమ్,
సార్కాయిడ్
లో బేసల్ యాంటీరియర్ ఇన్వాల్వ్.
మొన్నే కదా
బేసల్ యాంటీరియర్ సెప్టలా?
అవును,
బేసల్ సెప్టల్
కదరా పెట్టాడు.
బేసల్ సెప్టల్ యాంటీరియర్. ఓకే
ఓకే. Naxos disease
Yeah,
and
yeah.
Carvajal syndrome. So usually ARVC is autosomal dominant, but these two diseases are autosomal recessive. The Naxos disease has cutaneous manifestations like woolly hair and plantar keratoderma, and usually the penetrance of the ARVC is variable and it is less only. But the Naxos disease has very high penetrance to the subsequent generations. The Carvajal syndrome is a variant of Naxos. It is similar to Naxos with a predominant LV involvement. So the typical VT is usually LBBB morphology because it is coming from the right side and also with a superior axis, and typical T wave inversions extending to V3 or beyond. The classical monomorphic VT in ARVC with predominant RV involvement is generally well tolerated, even at rapid rates. This is because the LV involvement is less likely. So because of that, preserved LVEF, the VT can be well tolerated. But it is not unusual for a patient to die suddenly in spite of normal LVEF because the VT can degenerate into VF. So genetic testing. So
వీటి వస్తే ఎల్వి కూడా ఇన్వాల్వ్ అయింది కదా, లైక్ వన్స్ ఎరిథ్మియా వస్తే
ఇన్వాల్వ్ అవుతుంది కానీ ఎల్వి నార్మల్ ఈఎఫ్ ఉంటే టాలరేట్ చేయగలుగుతాడు కదా.
నార్మల్ ఈఎఫ్ ఉంటే ఓకే.
సో జెనెటిక్ టెస్టింగ్. సో usually if a patient comes with a DCM or cardiomyopathy which is idiopathic, we can send for genetic testing which can be categorized into different sequencing. So if we are suspecting a single gene which is very much associated with a particular cardiomyopathy, we can send for those single genes. Like if a patient comes with a suspect of ARVC comes, then we can write only ARVC panel that is assessed by Sanger sequencing. But this is usually useful to screen the family members when already the gene which is responsible is known in the proband. So they can test for only that specific gene in the family members. Otherwise, the next generation sequence based methods, they enable the parallel sequencing of several targeted genes. That is a pan cardiomyopathy panel. And further research studies can include whole genome sequencing and whole exome and whole genome sequencing. In that, we can apply a filter where all the whole exome and genome will be sequenced, but only parts of particular interest will be filtered out in the results. So if we want to retrieve the other areas of the genes in the future, we can retrieve when we have already done the exome sequencing, but which is not possible in next generation sequencing and Sanger sequencing. So a genetic test is generally performed in an index patient with either a clinical diagnosis that fulfills the clinical criteria for the disease in question, or when there is at least a reasonable index of suspicion. So the genetic testing with non-specific syncope or T-wave inversions confined only to the precordial lead V1 should be strongly discouraged. Currently, task force criteria for ARVC, the identification of pathogenic mutation categorized as associated or probably associated is weighted as a major criteria. So if a patient has a positive gene which is responsible for ARVC, then 50% of the diagnosis is already done. So patients with multiple pathogenic variants, they have more severe disease and earlier age of disease onset. So genetic testing. So for confirmed cases by task force criteria, it is class 2A to send for genetic testing, and for borderline cases it is class 2B. It is not recommended for those fulfilling only a single minor task force criterion. So if once after confirming, if we test for family members, over 1/3 of the family members will have a positive gene mutation. So pathogenic mutations are identified from 1/3 to 2/3 of the selected family members, and up to 40%, that is 1/3 of these individuals will fulfill the task force criteria for ACM. But even if the family member doesn't have a mutation, that is mutation negative, still he can have 80% chance of having a disease because we don't know all the genes which are responsible for ARVC. So if it is positive, it is okay. If it is negative, still we cannot rule out. So it is relevant because arrhythmia, sudden cardiac death can occur before the development of phenotypical characters, that is in the concealed stage itself. So if a patient, if the family member has gene positive mutation, then he has to be risk stratified to prevent the sudden cardiac death and arrhythmias. And also the pan cardiomyopathy testing, especially for the phenotype of prominent VT, VF or sudden cardiac death with the biventricular dilatation and systolic dysfunction of unknown cause, otherwise consistent with DCM, may also yield rare variants in the genes associated with ARVC. But if a patient with biventricular dysfunction comes with a predominant presentation as a VT for the first time, if we send for pan cardiomyopathy testing, there can be some genes which can come positive in a DCM patient also, but that doesn't mean that he has ARVC. So cascade family screening. Yield of the cardiac screening is highly varied due to age-related and typically incomplete penetrance. That's why about 1/3 to 2/3 of the patients, family members can turn out to be positive because of the variable penetrance. The incomplete penetrance and variable expression. There is age-related penetrance. Usually the onset is between second decade to the 5th decade maximum. So it is extremely rare for less than 10 years and more than 50 years. So highest probability is between 20 to 50 years. So it is class 1 recommendation that first degree relatives undergo clinical evaluation every 1 to 3 years, starting at 10 years of age. And the cardiovascular evaluation should include an ECG, the Holter, and echo or CMR. So cascade screening. So at least 3 generation pedigree chart should be done. This positive means mutation is positive. These are the affected individuals. This is the proband. These are the borderline task force criteria positive and mutation positive patients. This gray color. So these are the children of borderline as well as definitive diagnosed task force criteria, daughters and sons. So they also need a genetic evaluation and cardiovascular evaluation. So we do cardiovascular examination, genetic testing. If findings are consistent with arrhythmogenic cardiomyopathy, then ongoing evaluation and risk stratification should be done. And if genetic testing is negative and cardiovascular testing is also negative, no regular evaluation is needed, especially if genetic testing is negative. But if we don't do genetic testing, then we probably have to follow up them lifelong. And also there is a class 2B indication for exercise stress testing, that is arrhythmia provocation. It can be used as an adjunct to cardiovascular evaluation. So cardiovascular evaluation includes ECG, Holter, and imaging, plus or minus TMT. What does this TMT do? So during this exercise, because of the sympathetic drive, and also sometimes isoproteinerol can be infused during exercise to trigger the VPCs. So if patient can have multiple morphology of VPCs, but especially if the VPCs are having LVBP morphology with a superior axis, then it is more likely that a patient can have a ARVC in the future, even though if he may not be having it present. So if we send for a genetic testing, the mutations associated with the ARVC can be classified in these 5 classes. So the class 5 is pathogenic. That is based on the association of ARVC with these gene mutations, they are classified. So for a genetic, if a family member has class 4, class 5, then it can be concluded that they also have ARVC. So if a family member does not have a class 5 or class 4, they are dismissed for regular cardiological follow-up.
So LBBB superior axis favors
LBBB inferior axis can also be seen in idiopathic PVCs.
Yeah, correct.
So diagnosis is the difficult part in ARVC because there can be a lot of overlap with other diseases, and diagnosis is not definitive. Because of these things only multiple criteria are used, like Duke's and like rheumatic heart disease criteria. So International Task Force has recommended in 1994, which was modified again in 2010. So this includes 3 basically. One is structural and histological features, that is imaging and also tissue biopsy. One is the ECG and the arrhythmic features. And the most important thing is the familial feature. That is, if a patient has a positive gene mutation, 50% of the diagnosis is done. So they are subdivided into major and minor categories according to the specificity of their association. So they are highly, this task force criteria, they are high specificity, but they have very low sensitivity for early and familial disease. So in 2010, they have modified to improve the diagnosis and management. They have included CMRI also. So the modified criteria incorporated new knowledge on the genetic basis and also improving the diagnostic sensitivity, but maintaining the specificity at the same time. So it has included the biventricular variant and also left dominant variant of ARVC, AVC. The more advanced the disease, the easier the diagnosis. But the recognition of the earlier stages, which can manifest as sudden death without detectable structural abnormalities, can be difficult even with the 2010 criteria. And also, increasing use of CMR, there is a trend towards overdiagnosis of ARVC. So the diagnosis should be considered if a patient has exercise-related palpitations and syncope, survivors of sudden cardiac arrest, particularly during exercise, and with patients with frequent VPCs more than 524 hours, and VT of LBBP morphology in the absence of other heart diseases. So this is the task force criteria. So 5 divisions are there. So first is the imaging, that is structural. Second is tissue biopsy. And ECG. ECG again has 2, repolarization and depolarization abnormalities, and also arrhythmias. This has 3. And this is the basically Holter. This is the type 5. And next is the family history. So if we go into the family history, if a patient has a first degree relative who meets the task force criteria, that is one criteria. And that is if a patient has a relative who meets the task force criteria, or if a patient's relative has died of whom at autopsy it is proved that he is having this one, ARVC. And also if a patient's family member has identified pathogenic mutation that is associated with the ARVC. This is the major criteria. And the minor criteria, I am going this one based on each criteria, that is family history. So the minor criteria is if a patient has a relative who has possible ARVC, and if a patient has a relative who has died suddenly as a result of suspected cardiomyopathy, and the confirmed pathologically.
History of sudden death 50% మందిలో ఉంటుందంట. ఫ్యామిలీ హిస్టరీ. ఫ్యామిలీ హిస్టరీ.
ఇలా మైనర్ క్రైటీరియాలో వచ్చింది ఇది.
అందుకే అది ఎక్కువ మందిలో ఉంటుందంట.
Next, the most important is the structural criteria. This is by echo or MRI. This has certain numbers. So the first, the most sensitive is the first earliest thing is the dilatation of the RVOT. So we take 2 values of RVOT, one in plaques and short axis and long axis, 30 to 36, and one is the RVEF, 33. So the same thing, 29 to 32, 32 to 36 in short axis, and fractional area change 33 to 40%. So this is the
మేజర్ గుర్తుపెట్టుకుంటే చాలే మళ్ళీ. గుర్తుంటాయా?
Next is the MRI. So MRI, because MRI has volumetric assessment, which is very much reliable. So here they have taken volumes of the end diastole and also EF. Here echo has taken the diameters. So this has taken the volumes. So 110 ml per meter square, and this is 100 to 110. And RVF normally it is 45. If it is only 5% less, it is minor criteria. Here it is less than 40%. And if somebody has done RV angiography, JP sir has done RV angiography in one patient some 5-6 years ago. I think MRI was not very this thing. So they have done RV angio and they have documented RV aneurysm in RV angiography. And they have done CAT study. They have done electroanatomic mapping, voltage mapping for that this thing. The next thing is the tissue biopsy. Tissue biopsy is usually not done. I will tell the reasons why they are not done. So if the residual myocytes are less than 60%, by morphometric analysis. So this is less than 60%. The minor is 60 to 75%. The most important and reliable criteria is repolarization and depolarization abnormalities. So if a patient has inverted T waves in V1 to V3 or beyond in a child or adult more than 14 years, this is important because less than 14 years can have juvenile T wave inversions. That is also in the absence of RBBB more than 120 milliseconds. So that is the major. So if a patient has T wave inversions from V4 to V6, that is minor, not in V1 to V3. And also in the presence of complete bundle branch block, it is minor criteria. Next, epsilon waves are depolarization waves. At the end of the QRS to the onset of the T wave, they are seen in V1 to V3. That is the major criteria. These minor criteria, usually these are not used these days. So the late potentials by signal averaged ECGs in the absence of QRS duration of more than 110 milliseconds and also filtered QRS duration more than 114. And these four are actually signal averaged ECG criteria. These are no longer used actually. This one thing we can use is terminal activation duration. I will tell you in the subsequent slides. And the next is if you attach a Holter, if a patient has a NSVT or VT of LVBB morphology with superior axis, that is major. This is LVBB morphology with inferior axis, it is minor. Or if a patient has more than 500 ectopics per 24 hours Holter, it is minor. Okay, na? So this is the CMRA, which is showing dilated RV, and there is also LGE involving the epicardium throughout the entire endocardium, and also we can see some small saculations, which are small aneurysms. This is the histopathology of the biopsy specimen, which is showing replacement of the fat adipocytes with replacement of the myocytes by the adipocytes. And also there is some fibrosis, interstitial fibrosis. So
within a doubt, అది VPCs or VT with superior axis అంటున్నావు కదా, జనరల్లీ OT VT is common అని చెప్పావు కదా వీళ్ళలో.
అది డిఫరెన్షియల్ చేయడం ఎట్లా చెప్తాను, లాస్ట్ లో చెప్తాను. డిఫరెన్షియల్ డయాగ్నోసిస్ చెప్తాను. సో నాక్సోస్ అండ్ కార్వోజల్ సిండ్రోమ్ ఆల్రెడీ చెప్పాను. So there is something which is added in the recent task force criteria is ALVC. So these patients can have
ఇది superior axis ఉంటాయి, ఓవర్లాప్ ఉంటాయిలే. superior axis ఉంటే ARVC సస్పెక్ట్ చేయాలి.
ఏదంటున్నారు
వాడు RVOTVTs కూడా
నేను చెప్తాను, అది నేను లాస్ట్ లో చెప్తాను. ఇది ALVC, they can have genes which can overlap with DCM also. So it can be because of desmosomal protein mutations, laminin A by C, and ion channels like SCN5A and desmin. They can cause diverse phenotypes. The distinction here is from the DCM. So the ALVC diagnosis is relied upon documenting arrhythmias of isolated or predominantly LV origin in a proband or family members with cardiomyopathy not caused by ischemic, valvular and hypertensive diseases. These three must be ruled out like any cardiomyopathy. And the task force criteria 2010 has included LV disease and also added CMR for the diagnosis to increase the sensitivity while keeping the specificity at the same point. So ECG, so almost 85% patients demonstrate at least one ECG feature.
అవును, బైవెంట్రికులర్ ఎంత మందిలో ఉంటది మామూలు ARVC లో?
50%.
ఓకే. ALVC అంటే ఓన్లీ లెఫ్ట్ ఇన్వాల్వ్ అయినప్పుడు ALVC
predominant LV.
ఓకే.
So ECG findings are seen in almost 85%, but normal ECG can also be seen in 12%. So that's why we should do ECG, Holter and imaging in the family members, not the only ECG, because it has only 85% sensitivity. And also there can be dynamic ECG changes which can be observed as the disease progresses. There can be further prolongation of the S wave upstroke. There can be increased QR duration and development of the bundle branch block and precordial T wave inversions as the disease progresses. So repolarization abnormalities. As I have already told, the T wave inversions in V1 to V3 are seen in 87%, but they are seen in only less than 3% of young healthy adults more than 14 years of age. So the sensitivity is around 70%, but specificity is very high, that is 96%. So
that's a major criteria.
Yeah. So in a patients younger than 14 years, it is more frequently observed, especially in athletes. This is called juvenile pattern. So hence, patient older than 14 years, it is considered a major diagnostic abnormality. And if a patient has a complete right bundle branch block with T wave inversions from V1 to V2, it is regarded as minor criteria because the native right bundle branch block already has a reciprocal T wave inversion. And also, the presence of T wave inversions in the lateral and the inferior leads suggests LV involvement in patients with ARVC. And the next is epsilon wave. It is a low amplitude deflection located between the end of the QRS and the onset of the T waves in leads V1 to V3. They reflect the delayed activation in the RV, that is especially the basal peritricuspid RV region of the epicardium. The prevalence of epsilon waves is 1% to 25%. This signifies severe conduction delay due to extensive endocardial and epicardial scarring at that site. So this is not seen in everybody because it depends on the ECG filter setting, that is high pass filter and low pass filter, and magnification. And the next depolarization changes, which is easy to recognize, is prolonged terminal activation duration. That is measured from the nadir of the S wave to the end of all depolarization deflections. Usually it is less than 55 milliseconds in V1 to V3 in the absence of complete right bundle branch block. If it is prolonged, it is a prolonged terminal activation duration. So this is one of the pointer to differentiate ARVC from RVOT VT. If a patient has increased TAD in sinus, baseline sinus rhythm.
ఇంకోటి T wave inversions కూడా.
Yeah.
Baseline sinus inversions, T wave inversions ఉంటే కూడా differentiation.
And it should not be interpreted when a patient has an underlying bundle branch block because it will be obviously prolonged. And the next thing is ambulatory. We should do ambulatory the ECG monitoring for all ARVC patients. If it is more than 500, it is a minor diagnostic criteria. The signal averaged ECG, which has gone off use, it is actually averaging multiple QRS complexes to improve the signal to noise ratio and also to improve the detection of late potentials. So there are many criteria, that is filtered QRS duration more than 114 milliseconds, duration of the terminal QRS that is less than 40 millivolts is more than 40 milliseconds. That is the relatively late potentials are prolonged. That is almost suggestive of scar. So this was a minor criteria. In 2010, its use has largely declined due to limited sensitivity and specificity. So this is the typical ECG of a ARVC. As we can see, there is a epsilon wave from V1 to V4, which is starting at the end of the QRS and starting of the ST segment. So this is the late potential because of the delayed and slow conduction in the RV basal peritricuspid region epicardially and endocardially. And we can see the T wave inversion spanning from V1 to almost V6. So this is also one of the major criteria. Epsilon wave is also the major criteria. And also we can see some fractionation of the QRS, which also suggests the scar. This is the incomplete right bundle branch block. This is the complete right bundle branch block. If a patient has complete block, the specificity goes down. So these are the epsilon waves. And these are the T wave inversions seen in both.
A specificity epsilon wave.
Patient has complete right bundle branch block, the specificity of T wave inversions will go down. That's why it is regarded as It is regarded as minor criteria in the presence of complete bundle branch block. So the next is imaging, that is 2D echo and MRI. So the task force criteria has included akinesia, dyskinesia, and aneurysms of the RV, and also assessment of diameters and fractional area change. So it has added in 2010 the CMR for quantifying the volumes. So as I have already told, it is 110 and 90. So it did not include the RV myocardial fat or LGE, because in normal DCM patients also there can be LGE in the RV, and also because the RV wall is very thin, it cannot be quantified appropriately. And also the criteria does not have any diagnostic criteria for LV involvement. RV angio, it is the RVOT was the most commonly enlarged area. There can be that stack of coin appearance and excessive trabeculations seen in 50% and hyperreflective moderator band and saculations. These can be seen. So 2D echo, this is the plaques showing the dilated RVOT. This is the sacs showing the dilated RVOT. And these are the increased trabeculations seen in the apical 4-chamber view, dilated RV.
Plaques length 35.
Plaques
guideline.
Plaques lo
39.
39.
39.
29, 32.
32, 36.
Major. 32, 36.
32, 36. At least అదైనా గుర్తుంచుకోవాలి. 32, 36.
ఇందాక అన్నావు కదరా మైనర్ గుర్తుంచుకుంటే చాలా అనేది.
మేజర్ రా, మైనర్ కాదు. మైనర్ అవడే
మైనర్ లో వేరే ఇది ఉంది, రేంజ్ ఉంది కదా భాయ్.
Endomyocardial biopsy. So ACC-AHA consensus guidelines gives a class 2-year recommendation for endomyocardial biopsy in a patient with heart failure, in which a specific diagnosis can influence the therapy. But because of its patchy nature of involvement, there are high rate of false negatives and low sensitivity. And the conventionally, the RV septal biopsies or LV biopsies are not helpful because these are commonly spared. So using electroanatomic voltage mapping, that is mapping where the scar area is there, and taking a biopsy should be done, which is not reliable, which is not practical. So, and also there is increased risk of perforation and tamponade with RV free wall biopsy, which is the most common involved. So the electrophysiology testing. So the low predictive accuracy of electrophysiology testing in identifying those at risk of SCD and life-threatening arrhythmias. So it is usually not recommended. So it is recommended only in patients with refractory VT for ablation considerations, and also to differentiate RVOT VT from the ARVC VT. And also this is not related to electrophysiology. Frequently VPCs and VT occur in almost 2/3 of the patients. Minute ఇది ఎండ్ అవుతుంది, ఇంకో కొత్త లింక్ క్రియేట్ చేసి పంపించండి.